we're in a kind of anomaly in the sense that we arrived back when we started among independent practices who wanted to think differently about what we were providing to our community. And as a result, we selected one common EMR. And to Joe's point, there are so many IPAs and PHOs have 10, 12 different EMRs. And just, I mean, I have hallucinations just managing one, much less thinking managing 10. And we have a big vendor management meeting next week because what we all want is trusted, validated data. Right. No physician wants to have data in front of him that doesn't represent his patient population because he can't trust it. And so we spent, as I was telling Sandra, that, you know, we say that the EMR is a tool. We spent millions on it, but it's a tool where 90% of its validation and trust comes from the people making sure. It's garbage in, garbage out. Right. If we don't work at the elbow to make sure that people enter data correctly at the use of the template, so every time a diabetic comes into our offices, we have to ensure that the MA and the physician enter the data, because somebody texting or transcribing data into a field is not data. And so those are the things that we have to train people to understand, that if you want trusted data. The irony of all this is, which I really enjoy, is that I can't think of a physician I know that wants to be, including Maria, in the lower quartile of anything.
That's for sure.
And they're very competitive, and they see how they benchmark. So we transparently benchmark all of our data by practice, by provider, diabetic, heart disease measures, prevention measures, and they have quality boards in each office, and they can see literally, how did Fred do so much better on Pneumovax? Well, then we share best practices. And so that starts the journey, and they build pride in the fact that they're improving their measures and taking care of their patients by the fact they have trusted data.
That's correct.
And that takes a long time to get there. The other thing I need from Joe, and I think that's where we're heading, is I need your claims data. Because I can now document that we're improving our quality of care and our prevention measures, but did it result in the run rate in terms of taking cost out of the system for your attributed patients? So now we've got to figure out how to marry that, because I don't have a health plan like Sandra who can look at both of those pieces, but if I'm going to partner with you, I need that data to say, did our measures and the work we did in quality performance improvement translate into cost savings for that population that you're insuring?